Hello, my name is Dr. Ukiri Richard. I continue my podcast on basic cardiology. Today we are going to talk about fever and shiver. The case I'm going to use to demonstrate this shivering case with fever is that of a 75-year-old man with oliguria and dysuria who has been having recurrent urinary tract infection in the past years due to prostate hypertrophy, and he came to you for the first time with shivering, with also general feeling of sickness. What are you going to do about this patient? I will take a detailed history as well as a good body physical examination. I will do urine analysis, urine culture, and if possible, if necessary, I will give a transurethral catheterization and also do an abdomen sonography to look for congestion of the renal pylon. I will also check for remaining urine volume in the urinary bladder after urination. I will do blood tests to check for parameters indicative of infection. That is the full blood count. Also check for electrolytes and the renal function, and also PSA. Okay, in the physical examination, the general condition was mildly reduced, but the physical condition was good. He was pale. Jugular venous pressure was normal. The pulse, the lungs were free. Blood pressure 90 or 60 millimeters of mercury. You could hear a low systolic murmur above the ebb point. There were no pericardial rub. Irregular heart rate of 100 per minute. Temperature was 39 degrees centigrade rectal. Abdomen was soft. There were no tenderness, and you could not palpate the urinary bladder. Liver was normal. Spleen okay. Could not be judged. There were no peripheral edema. Peripheral pulse were palpable. There were no neurologic deficiencies. In the past history, you found out that the patient already had a three times bypass operation, or three-way bypass operation in coronary artery vascular disease with a normal left ventricular function, and also has a 2-chamber pacemaker implantation 6 months ago due to AV block 3. He's known to have arterial hypertension, prostata hyperplasia. He goes to regular control with urology, but sometimes, until now, there were no indication of malignancy. He has been having a lot of urinary tract infection in the last months and have been getting antibiotics for them. Since the bypass operation, his general condition has been reducing. His present medications are aspirin 100 mg, bisoprolol 5 mg, ramipril 2.5 mg, and simvastatin 20 mg. In the urinalysis, nitrite was positive, glucose negative, leukocyte 3 pluses, erythrocyte 1 plus. In the laboratory analysis, leukocytosis 14,000, hemoglobin 10.3, thrombocytes 244, creatinine 2.1 mg per dl, potassium 4.8, CRP 228 mg per dl, PSA 1.5 nanogram per milliliter, and procalcitonin 0.62 microgram per liter. Normal is up to 0.5. You did the abdomen sonography, which could not really be assessed due to high peristaltic movement and air. As far as can be judged, the renal pylons were okay without congestion. There were 2 renal cysts on the right side. The left kidney was okay. There was a remaining urinary volume in the bladder of 400 milliliters. There was light splenomegaly. The gallbladder could not be seen after a cholecystectomy. So you did an ECG, which I will tell you the findings. You actually saw that the ECG had the frequency was normal with a rhythm of atrial fibrillation. Well, it was a ventricular stimulation through the pacemaker, which is bipolar with VVI mode, but you could see some intrinsic actions. You saw signs of sensing problem, which is under sensing, because despite adequate intrinsic rhythm that the patient had in some cases, you saw that there was a continuous ventricular stimulation, which led to an earlier than normal or a premature QRO complex, or sometimes ineffective stimulation when it happens in the refractory phase. So you required for the pacemaker pass of this patient to see the constellation and to do the pacemaker check and also the anticoagulation of the patient. You did the pacemaker check and you saw mode. The mode was a mode switch due to the atrial fibrillation since 8 weeks. The ventricle sensing, you saw that there was serious fluctuation in the values. The ventricular sensing, since the operation has significantly reduced to 2.0 millivolts, and you also saw a rapid rise in the impedance of the ventricle electrode from 600 to 1500 ohms just weeks after implantation. What are you going to do in this case? I will definitely change the sensing from 2.0 millivolt to 1.0 millivolts. Are you going to continue the management on outpatient basis, or will you admit the patient? Because of the information we have gotten, the patient should not be discharged, especially due to the reduced general condition and seriously significant infection constellation, the renal function dysfunction, which is not clear if it is new or old. Also, we are not sure if a new urinary tract infection is present. The clinical presentation and the significantly elevated labochemical infect parameters, as well as the sonographic finding of splenomegaly, are all indicative of a beginning septic process. I will take blood culture and begin a calculated antibiotic management. Additionally, we are seeing an atrial fibrillation for which we do not know how old it is, because it was not known before now, which, if we are planning a cardioversion, will require an anticoagulation. Also, the patient has an additional intermittent sensing defect in the heart pacemaker, so the patient has to be admitted. Could you please define the terms sensing defect and pacing defects? Sensing defect and pacing defect. What are the possible causes and what are the symptoms? Well, sensing defect in this case is actually a wrong or failure of interpretation of the actions of the stimulated ventricle. Under sensing, that is when the intrinsic actions cannot be correctly recognized. The pacer will continue to stimulate independent of the intrinsic actions. The pacemaker impulse can stimulate in the vulnerable phase. Causes for this could be a wrong programming of the sensing, could be cable defect, it could be electrode dislocation, could be changes in tissues like scars, infection, edema, ischemia in areas of the electrode tips. The symptoms can be mild or be as serious as sudden heart death due to when the stimulation occurs in a vulnerable phase and triggering of a sustained ventricular tachycardia. Oversensing means when the pacemaker recognizes signals that are wrongly interpreted as intrinsic ventricular contraction stimulation. Causes for this could be wrongly programmed sensitivity, could be exogenous disturbing potentials like electrical instruments. Functionally, symptoms in the cases of pacing defect, functionally the symptoms here are usually indicated as pacing defect because the pacemaker is not stimulating even when there is no intrinsic action. I'll tell you the symptoms in pacing defect. So we have talked about sensing defect. Sensing defect, you have undersensing and oversensing. Now we are going to talk about pacing defect. The pacing defect, that is when the pacemaker impulses will not be correctly answered, which is also called exit block. The causes could be defect of the electrode, local tissue changes, or threshold rise. It could be an electrode dislocation with phases of contact problems. The symptoms here are bradycardia, dizziness, syncope, up to death from asystole because of in patients that are really dependent on pacemaker. Please, my question now is, could you bring the problems of these patients together and tell me which additional examination will be helpful? Chest X-ray will help to tell you if the electrodes are in place, if there's a dislocation, or if there's a cut. There may also be a connection from the pacemaker aggregate. Echocardiography, other transthoracic or if necessary transesophageal, will also help to see the electrode position and check if there is pericardial effusion. So you did the chest X-ray where you saw that the electrodes were in order. There was no pneumothorax, no congestion signs, no infiltration, and you saw some pleural effusion, mild ones on the left. In the echocardiography, the pump function was okay. There was a synchronic septal movement with in total hyperdynamic contractile left ventricle. There were no other regional wall motion disturbances, and left ventricle was normally gross size. There was light left ventricular hypertrophy. Both atrium were mildly dilated. Right ventricle was okay. Aortic root was normal. Aortic valve was a bit sclerosed. There was reflux on the mitral and tricuspid valve. The pressure gradient across the ROV, ROA was maximum 30 millimeters of mercury plus central venous pressure. The inferior vena cava was collapsed. The pacemaker electrode could be localized in the right atrium and right ventricle. The middle part of the ventricle showed two localized echogenic structure of 5 by 8 millimeters and 5 by 5 millimeter. The differential diagnosis here is either thrombus, vegetation. There were no pericardial effusion. You went ahead to do transesophageal echocardiography, where you were able to see the pacemaker electrode very well, and you saw more echo arm structures. They were lying close to each other with a maximum diameter up to 10 millimeter. The tricuspid valve was a bit sclerosed with mild regurgitation. There were no vegetation on the tricuspid valve. The other valves were sclerosed with regular movements, and there was regurgitation of the mitral valve. You saw minimum small spontaneous contrast in the left atrium, but there were no thrombos in the left atrium and left atrial appendage, despite the low flow of 0.2 meters per second. So my question now is, what case are we dealing with now, and what are you going to do for this patient? We have a case of pacemaker electrode endocarditis. This usually comes about through contamination with local bacterial flora, usually Staphylococcus aureus, during implantation. The infection spreads along the electrode up to the endocardium and the electrode tip. Even the hematogenic spread of an already removed focus is also possible. That means an already infectious focus that can be removed that has the hematogenic spread can also cause this pacemaker electrode endocarditis. To get to the diagnosis is very difficult, as is also by endocarditis, especially the left cardial heart valves, because clinically you have very little respiratory symptoms, which are caused from spread into the respiratory tract or the respiratory circulation, so to say. Infectious signs or immune phenomenon. Apart from that, like for endocarditis, you have signs of valvular regurgitation or arterial embolism. The Duke criteria is usually not too sensitive here. It is advised to modify the Duke criteria here and use the local infection signs as well as pulmonary or septic embolism as HOPT criteria, which I mean main criteria. So here you will give you take blood culture according to guidelines. You give antibiotics according to guidelines calculated with evidence of the bacterial you can culture. Of all cases, you must give it 4 to 6 weeks as recommended. You have to do an electrode explantation. You have to do an extraction or explantation. To begin an anticoagulation is not recommended. You have to program the pacemaker to raise the sensitivity. Electrode removal, electrode explantation, electrode extraction. Possible ways are given in the CDRIE and definitions. When you talk about electrode removal, you mean removal of the electrode irrespective of the technique and the time after explantation. If you talk about electrode explantation, you are talking about removal of the electrode without additional help, like just through manual pull in through the implanted vein in an electrode that has been implanted less than 1 year. That is the electrode explantation. Then the electrode extraction. This is the removal of the electrode with additional help or devices. For example, removal mandrel, which is the locking stylet, laser or surgical sheets, independent of the implantation dates of the electrode. Electrode removal when the electrode is more than 1 year implanted. You can get the recommendation for electrode removal, explantation or extraction through in the German translation of the NAPSE recommendation with commentary of the German cardiology of cardiologists. Here you will see the recommended personal and infrastructural requirements. I would like to let you know now this electrode removal is the most difficult operation that has to do with pacemaker. So you really need a very experienced operator to do this. My question now, what are the indications for electrode removal? 1. Sepsis, that's a systemic infection with or endocarditis through a documented, that means microbiologic cultured infection of an intravascular part of the pacemaker system or through a pacemaker aggregate infection when the intravascular portion of the electrode cannot be made aseptic. 2. When you have a life-threatening arrhythmia triggered through an electrode fragment. 3. Electrode or fragment of the electrode or pulled part of the electrode with parts from the electrode that are causing acute danger or stand to present life-threatening danger to the health of the patient. Then 4. Electrode or electrode fragments that have clinical relevance of a thromboembolic event. Let's talk about endocarditis. Management and prevention of endocarditis in patients with heart-rate pacemaker or ICD. That means CDRIE. CDRIE means cardiac device-related infectious endocarditis. 1 or A. In recommendation for pacemaker or ICD, that is CDRIE, cardiac device-related infective endocarditis, is a prolonged antibiotic therapy and removal of the pacemaker or ICD by the CDRIE recommendation. 2. Removal of the device by CDRIE removal of the device should be carried out according to CDRIE recommendation when any other occult infection focus cannot be found. And 3. Patients with valvular endocarditis, either native or prosthetic, that have additional intracardiac device, the extraction of the same should be done. Now, 2, let's talk about the type of device removal. The device of removal could be percutaneous extraction, surgical extraction. The percutaneous extraction is recommended even if the vegetation is more than 10 millimeters. Surgical extraction comes into play when the percutaneous is not complete or not possible, or when there is associated destruction of the tricuspid valve endocarditis. Or when there is possible or associated destroying tricuspid valve endocarditis. And 3. Surgical extraction is recommended in patients with very, very big vegetations above 25 millimeters. 3. After we talk about the therapy, type of device removal, now we are going to talk about reimplantation. The reimplantation, after removal of the device, the indication for implantation should be checked again. If the reimplantation is necessary, this should be done at least within days of weeks and under antibiotics cover. Temporary pacing is not recommended. Prophylaxis. We recommend routinely antibiotic prophylaxis before device implantation. What do you do now when you have to do an electrode removal in a patient that is completely dependent on the pacemaker. Principally, you could do a cardioversion, which is also naturally also a defibrillation in patients with pacemaker, but this can lead to loss of capture or irreversible damage of the pacemaker and inhibition of the pacemaker function. This electrocardioversion could also cause a stimulation in VVI mode or asynchronous constant frequency stimulation. Because of this above, you have to take care of the following. 1. Before cardioversion, I think I am missing the question, sorry. My question is, what do you do when this patient is completely dependent on pacemaker? In that case, with this kind of constellation, it has to be an interdisciplinary management with a heart thorax surgeon, and a procedure that will be adequate for the patient should be laid down. The heart surgical stimulation through an epicardial electrode is also a possible way. Okay, that's good. Let's come to now the cardioversion. The patient we are talking about now is not dependent of pacemaker. Due to suspicion of electrode endocarditis and due to a new atrial fibrillation, the patient was admitted and given calculated antibiotics and a PTT controlled anticoagulation with heparin. After culture of Staphylococcus epidermidis in 2 different culture medium, the antibiotic was changed. Thereafter, the electrode could be removed without complication, and the electrocardioversion was done in this patient with atrial fibrillation. Now, my last question for you is: patient with pacemaker and need to carry out electrocardioversion, what do you really have to watch out for? That is what I was answering before. Patient with pacemaker can actually undergo electrocardioversion or defibrillation, but don't forget that it can lead to loss of capture. It can lead to irreversible damage of the pacemaker or a temporary inhibition of the function. The electrode can change to VVI modus or an asynchronous fixed frequency stimulation. So the following should be watched out for: before cardioversion and immediate thereafter, the parameters, the measured value, stimulation and sensing are up to all to be noted, and the function of the pacemaker should be checked again. 2. Anterior and posterior application of the electrode, which is the energy vector, to bring them in horizontal energy vectors to the electrode even, so as to minimize the energy involvement of the stimulating electrodes. 3. You put the pedals 15 centimeters away from the pacemaker, as the pacemaker aggregates. And 4, use as little energy as possible. Thank you very much.